Hello, I'm Ileana Piña from Thomas Jefferson University in Philadelphia, Pennsylvania, and this is my blog. A little bit different blog because I'm really interviewing a good friend about these GLP-1 inhibitors. Some of our heart failure patients are getting their GLP-1 inhibitors from their primary care physicians. But a lot of questions have arisen with the trial called Summit. And so with us today is Barry Borlaug, who is in charge of the research section for the cardiovascular section of Mayo. And that is Mayo, Rochester, where it must be much colder even than here in Philadelphia. So Barry, congratulations on that trial. Tell our audience a little bit about how the trial was structured, because it's important how we get into your information.
Thanks, Ellie. So Summit was a randomized double-blind placebo-controlled trial testing the GLP-1 GIP agonist tirzepatide versus placebo in patients with HFpEF. And unlike some other trials, this was real HFpEF 50% or above ejection fraction. And patients were randomized 1-to-1 to tirzepatide, titrated up to 15 milligrams once weekly or placebo, and treated for a minimum of 52 weeks. The dual primary endpoints were worsening heart failure or cardiovascular death, quality of life by the KCCQ clinical summary score. The median duration of follow-up was 2 years, and we continued follow-up until the last patient enrolled completed the full 52-week period of treatment. And we found that as compared to placebo, tirzepatide reduced the risk of worsening heart failure or cardiovascular death by 38%, which was statistically significant, and also improved KCCQ clinical summary score. In addition to that, we also looked at other patient-centered outcomes like 6-minute walk distance and other biochemical markers like CRP. We saw that there was also a significant improvement in exercise function measured by 6-minute hall walk distance and about a 40% decrease in CRP levels.
How long did the total trial last, including the time that the drugs were being administered?
The longest duration of follow-up was 3 years, and the median follow-up was 2 years.
Were any of these patients also on SGLT2s?
Yeah, a minority of patients were also on SGLT2 inhibitors, about 17%.
What was the baseline KCCQ score?
Very poor. As you know, physician-reported heart failure severity often doesn't agree with patient-reported, and 72% of the patients were judged by their physicians to have class 2 heart failure, but the mean KCCQ score was just over 53. So pretty severe patient-reported limitations, severe HFpEF. Despite this, and is often the case in HFpEF and obesity-related HFpEF, the median BNP, NT-proBNP, was only 175.
I was very surprised at that. Very surprised. That really is low.
Yeah.
That was NT-proBNP. That wasn't BNP.
Exactly.
So things that don't match, but I think that's HFpEF. When you lose the fat, you lose the weight. You just lose it in the rest of the body. Where else have you looked? And what did your CMR study show?
We did do a CMR sub-study. This is a smaller cohort of all patients that were participating at centers in this additional voluntary study. And cardiac MRI was done at study entry and then at 52 weeks. And the primary endpoint of that was change in LV mass, because we know from prior studies looking at weight loss interventions that LV mass is the most consistently reduced measure of cardiac structure and function. And indeed, we found that to be the case. There was a statistically and clinically significant reduction in left ventricular mass by CMR. We also looked at pericardiac fat. Visceral fat is defined as fat stored around internal organs, and it may be present in the abdomen, abdominal visceral adipose tissue, in the mesentery, things around the kidneys, but also it exists around the heart. And then within the pericardial space, that's called epicardial adipose tissue. And then around the pericardium, there's pericardial adipose tissue. So we combined those two, refer to that as pericardiac adipose tissue. And that also was markedly reduced by tirzepatide as compared to placebo.
And I also noticed the reduction in LV mass, which you just mentioned. But what kind of reduction? Do we know microscopically what's different about that muscle? Have you been doing that?
That's a really important question. And when people lose weight with incretins or most weight loss therapies, it's not just fat; it's skeletal muscle mass as well. The amount of that was lost in the Summit trial is not known because you need to do more advanced evaluations to assess that. Things like DEXA or imaging. So that was not performed. So we can't make any inferences as to what extent it was fat loss versus lean tissue loss versus water loss or something like that. But that is a significant issue with these drugs and with all weight loss interventions. So I think we need more dedicated mechanistic type studies to look more carefully at that.
Do you know any data about just regular skeletal muscle with these drugs? Because the patients complain to me, besides their stomachs not feeling just right, that they feel like they're losing their arm muscles, for example.
Mm-hmm. Part of it is if you weigh 20% more, you're carrying all that extra weight around all the time. So you're basically conditioning your skeletal muscles to hypertrophy, your calves and the rest of the locomotion muscles to carry that excess weight around. So that stimulus is lost. But then, of course, as people are eating less and maybe being a little less active, they do lose some muscle. And I hear that from patients too, that complaint that they do, feel a little less strong than they used to. And I think that that's a really important avenue for further research because, as you know, people with HFpEF, about 2/3 of them are living with obesity. But many of them have what we call obese sarcopenia. So they're obese by BMI criteria, but they have limited skeletal muscle mass and strength. Both the quality and the quantity of skeletal muscle is down. So that's something that we really need to be doing a better job of addressing, I think, either pharmacologically or with training, like exercise training interventions.
Heart failure alone will make your skeletal muscle change. Do we know what type muscles are changing, if at all?
Not yet. We're conducting a separate study right now, a federally funded trial of semaglutide, a different GLP-1 receptor agonist. And as part of that trial, this is also an obesity-related HFpEF, we are in a subset of patients performing fat biopsies. So we'll get a better sense of fat. We're not looking at skeletal muscle. I kind of wish we would have set ourselves up to do that. But I think that's a really hot topic, something we need to look further into, all the way down to the microscopic level. What's happening in terms of the types of muscle fibers, type 1, type 2, atrophy, what's happening to intramuscular fat and intermuscular fat. These are really commonly seen with older age and with diabetes and HFpEF. So these are all really important to characterize.
And do we lose mitochondria?
Yeah. It's an unknown. It's a really important question. It's also possible that the mitochondria work better with the weight loss because, as your insulin sensitivity gets better, your glucose disposal gets better, your oxidative stress goes down, your inflammation goes down. All of those things may enhance mitochondrial biogenesis. So this is really important that I think you'd really need to do like skeletal muscle biopsies before and after with really sophisticated assessments. And that sort of study is really urgently needed, I think, to better understand what's happening.
This is right up your alley. I could see an NIH study being put together. Something that I've started doing with my patients is I have them on resistive training because if they're really losing that muscle, what's going to take the place of the muscle is called fat. And they're going to have hanging fat pads. So I have them trying to do weights and TheraBands and things like this. So there's another piece of a study that could be added to it. So I think there's just so much we still don't know.
When people lose a lot of weight for a variety of interventions, like intensive lifestyle, recidivism is high and they often gain it back, but they usually don't gain the muscle back. They just gain fat back. They end up in a place that's even worse where they started off. So this really is an important issue.
So what's next for you?
Well, we are going to continue to look at the summit trial results. As you know, there's always the usual multiple questions that we can address in more detail with secondary analysis. So we've got more of those to work on. We're currently doing another clinical trial, as I mentioned, with semaglutide. It's different than like the HFpEF studies, which we're looking at, quality of life and 6-minute walk distance. We're looking really specifically at the hemodynamic effects of weight loss with semaglutide. So we're doing a rest and exercise invasive cardiopulmonary exercise test. And we'll finally be able to see, is LA pressure going down? Is it wedge pressure with exercise going down? What's happening to pulmonary pressures?
What's the mandatory parameters?
The main endpoints will be pulmonary wedge pressure, exercise and rest, of course, but all of the hemodynamics, exercise performance, peak VO2, body composition, cardiac MRI, you name it. We're looking at as much as we can.
You have a lot to do for the few years. Well,
you could say that again.
Thank you so much for joining me today. I thought this was such an important topic that it really needed to be played out. These drugs are getting to be so common. And sometimes patients don't even think about it. They're giving me their list of medications, but they leave those out.
Yeah.
So I have to ask them very specifically, are you getting these medications from your primary? Because I certainly haven't started giving them away. So this was very timely because I think a lot of clinicians are going through this right now and really don't know what to say to the patients, but maybe even testing how does resistive training improve while they're on the drug so that you don't lose a lot of that muscle mass, the external muscle mass, actually change their activity level. Good luck with the rest of these studies. It's really fascinating.
Thank you, Lily. It's always great to talk with you.
Thank you. So this is Ileana signing off with hopefully some good points today. Please stay tuned. We're going to pursue some of these avenues of education for better care of our patients. Have a great day.